much, ma'am, for your kind introduction. So today, the first case which I'm going to show is a case of a posterior polar cataract. We all know that the posterior polar cataract is a nightmare for any phaco surgeon because there are high chances of posterior capsule rupture. So this is a typical onion ring shaped true posterior polar cataract where posterior capsule is very weak or it may be defective in that area. So can you start the video, please? So the whole idea in the posterior polar cataract surgery is to try to delay the opening of the posterior capsule as much as possible. So all our maneuvers are targeted towards that. So I can't emphasize more on the sizing of the capsular Rhexis that it should not be more than 5.25 millimeters, because if there is a uncontrolled PCR, we need to put a 3-piece IOL, and for that we need to do optic capture. So now after doing slight hydrodelineation, it's a grade 2, grade 3 cataract. So I go ahead and give the first chop and see I'm not separating them more laterally so that there is no traction or no pressure on the posterior capsule. So that I take out the first piece from the capsular bag and tilt the phaco probe on the other side and take out the second piece. So we try to avoid the rotational forces as much as possible so that the posterior capsule doesn't open up at this stage. And this is the last nuclear piece which you take out. And now I go loosen up the whole epinuclear material all around the 360 degree. And this is the central plaque which you can see is the area which is attached firmly to the posterior capsule, and it should be taken up in the last. So I'm just loosening up all the epinucleus all around. And once I loosen up the epinucleus, then I try to take off this epinucleus. So these are the last pieces. And now see, still the central posterior polar opacity is there. And now this whole area is flipped off. And as this is a true posterior polar cataract, as this is flipped off, the posterior capsule opens up. And now at this stage, remember to not withdraw all the instruments from the eye suddenly. Just go ahead and put viscoelastic, stain the vitreous with the triamcinolone, and do bimanual anterior vitrectomy to clear off all the vitreous from the anterior chamber. Without doing this complete anterior vitrectomy, you cannot go and take off this cortical matter. So remember, if you have a PCR and vitreous in anterior chamber, is not the end of the game. Your game has just begun. And this will be very crucial for the post-operative follow-up of this case. So again, I'm maintaining the anterior chamber at every stage. After doing complete anterior vitrectomy, you can easily strip off this cortical matter from all around. So I go ahead from one side, take off the cortical matter. And once go ahead and put viscoelastic before changing my hands. So I take off the aspiration cannula, put viscoelastic again, and change my hands. And this you can only do if you have done complete anterior vitrectomy from the anterior chamber. That's why it's very important that you stain the vitreous with triamcinolone. And so this is the last pieces of cortical matter, and you can see a vertical defect in the posterior capsule. Again, you maintain the anterior chamber, and this is a 3-piece IOL. Remember that your leading haptic, it goes horizontally behind the iris, and you just turn it in the anti-clockwise direction, and then dial the trailing haptic in the sulcus. And now here the importance of the sizing of the anterior capsular Rhexis comes into play. To capture, you need Rhexis not more than 5.25 millimeter in size. So I go ahead, use a Q-glance hook, put OVD, and tilt the optic on both the sides to capture it behind the anterior capsular Rhexis margin, and check on both the sides that we have captured nicely. Again, do limited anterior vitrectomy to clear off whatever vitreous is there. And once you are done with this, I go ahead and put Miocol. And this all surgery is under topical anesthesia, you can make out. And then again, I go and hydro stitch all my incisions. and this finishes the case. Now let's see the post-operative photograph of the patient, that how did this patient behave. Now see, this is the IOL, 3-piece IOL, which is locked nicely because of the there's the optic capture, so that it gives a long-term stability to the IOL. So with this, I'll end my first video. Thank you very much, ma'am.
That was a wonderful teaching video. I think we got to know all that we need to do in polar cataract. But something now that we are investigating a lot now, do you think you would like to add an anterior segment OCT evaluation pre-op in these polar cataract? This was a very obvious cataract where you know you're going to have a PCR. But sometimes in some of these cases, you could actually avoid planning a toric IOL in those cases when that anterior segment OCT tells us that there is a possibility of posterior capsular dehiscence. So, what do you think
of
about
course,
that?
we do anterior segment OCT, ma'am, and it definitely helps you. So basically, but still the your counseling to the patient, it never changes. Even if we do anterior segment OCT, we always take it that if it's a true posterior polar cataract, there are high chances that it will open up. So we need to be careful. And moreover, toric IOLs, if it opens up like this, in this fashion, where we can't convert the posterior capsular, it's a new posterior capsular axis, we can't put a toric IOL because there is no toric which is available in 3-piece. So of course, we need to explain to the patient, I have backup of the lenses available in these cases.
Yes, Dr.
Arup?
Yeah. So Harshul, I think I have to congratulate you for a case that was very well done. A little comment on, a small comment on the vitrectomy technique.
Yeah, even I wanted to ask that.
Yeah. So now, after doing the vitrectomy, which was very well done, I would not switch over to the irrigation aspiration handpiece. I'll use the same vitrector, and the same vitrector now will be using an irrigation aspiration cut mode, you know, so that you remove otherwise it takes a lot of time and, you know, you really have to, go through the incision and come out several times. Very well done, surgery.
One more point I wanted to say, Harshul, very well managed. Only two things is, when your vitrectomy was over, I saw a rectangular PC tear. And when you showed up post-op images, it was a linear tear going almost beyond the CCC and beyond. I was just wondering, could you have placed a single piece IOL in the bag, horizontal to that of the tear, instead of putting a 3-piece in the sulcus, which is of course the right thing to do. But could we have gone ahead and done a single piece IOL in the bag? Because I thought your
with such a long linear tear, ideally it should not be. If you can see the edges.
I also somehow feel that to place a single piece in the bag with the posterior capsule open, you should convert it into a PCC if you can.
Yes.
Then placing a single piece in the bag makes more relevant sense. Then the way he did it was the best.
Lovely.
Transilone which you used, I really want to ask all of you. I would do a vitrectomy first, then I would inject triamcinolone acetonide to know whether there's any residual vitreous, and then I would go ahead and complete that cutting. Would you all of you inject triamcinolone right in the beginning itself?
Beginning.
At the beginning,
Beginning, there's some recent reports where you have a single piece IOL in the bag with a PCR, and then you actually do a optic capture so that the optic is brought out of the the Rhexis, and the thick haptics still lie within the thing. Now, I've never done this. And I'm not sure how good it is.
There has to be an angulation of the haptic to the optic to do that. That optic capture in a single piece, even I've read that article, 2-3 of them, but it doesn't.
There's reverse optic capture you're talking about,
Basically, it's of a single piece acrylic IOL.
But there are chances that.
the panel's opinion, because I've not done this, and I'd like to know their opinion as to how good this is even to prevent UGH also, because you still do have a thick optic which is lying, so, and you might have.
Let me address this issue. See, now supposing if this is a primary surgery where I have to implant the lens, I would go do what Harshul had done. But if I was dealing with a case where, the Rhexis is intact, there's a huge PC rent, and there's already a single piece hydrophobic acrylic lens in the bag which is getting decentered, which has got dislocated. So that particular case, instead of trying to bring it out, cut it and expand it, I would relocate it in the bag, the haptics, and bring the optic in the reverse optic capture and put it in front of the capsule. See, it is a vitrectomous dye. So I don't think there is the issue of though that they have a square edge have optics and all that, very very sharp angulation and all that, but still it will not rub against the iris pigment epithelium as much as it would if it was a non-vitrectomist dye.
You mean because the whole thing falls backwards a bit?
Yeah. It said the vitreous segment, the posterior segment has been decompressed to a certain extent, so the whole the bag will be located a little posteriorly. But I will never do as a primary procedure. No.
The Rhexis size also, I think, matters. If you have a larger Rhexis, then this doesn't stay. So it tends to, you can't capture. So you have to have the little smaller Rhexis, then you will be able to capture.
Shall we go on to your last video, Harshul?
Yes, ma'am. Can I have my video, please?